Welcome back to Sleep Medicine and Physical Therapy. Part 4, Sleep in Specific Conditions. Today's topic is sleep and chronic pain interlaced influences, guidance to physiotherapy practice. This is Chris, physiotherapy student, and let's start. What is pain? Pain was recently redefined by the International Association for Study of Pain, IASP, with more precision since the 1979 definition. Pain is now defined as an unpleasant sensory and emotional experience in which a difference is clearly made between pain, nociception, and the person who experienced it. The recent joint effort of the IASP and the WHO resulted in a classification system for chronic pain syndromes. Nowadays, chronic pain is recognized as a disease, namely chronic primary pain. Thus, pain can be categorized as primary, such as fibromyalgia, complex regional pain syndrome, chronic primary headache, orofacial pain, or other chronic musculoskeletal conditions such as osteoarthritis, rheumatoid arthritis, or ankylosing spondylitis, but also as secondary if the pain is tributary to an underlying disease such as cancer-related pain or secondary headache, among others. The understanding and comprehensive analyses of pain characteristics are essential to optimize treatment efficacy and promote the best prognosis for individuals with chronic pain. Nonetheless, the assessment of the pain patient should not be limited to pain. From a biopsychosocial perspective, different biological, psychological, and social factors can influence the origin, perpetuation, and progress of the chronic pain. A variety of aspects can significantly modulate the pain experience, such as higher psychological distress, kinesthesia, or lower social function, and general biological factors. One of these aspects is sleep, which has been consistently associated with acute and chronic pain over the years in a wide variety of populations and interacts directly with pain. The comorbidity between chronic pain and sleep disturbances. In 2015, the National Sleep Foundation conducted the Sleep in America poll and showed that poor sleep quality and sleep debt were related to increased pain complaints. People with acute pain slept an average of 14 minutes less than they needed, and people with chronic pain slept 42 minutes less per night than they felt they needed. Another interesting finding of this poll was that people with both acute and chronic pain reported sleep often was fragmented by environmental factors such as noise, light, temperature, and an uncomfortable mattress. Regarding sleep duration, average adults require between 7 to 9 hours of sleep, with less than 6 hours and more than 9 hours correlating with increased pain the next day. In addition, sleep for 3 hours or less was associated with an 81% increase in pain intensity compared with sleeping 6 to 9 hours, and sleeping for more than 11 hours was associated with a 137% increase in pain intensity. In this sense, it is not only lack of sleep, sleep deprivation, and sleep disorders that affect pain perception, but surprisingly, an increased amount of sleep can also affect pain perception. In chronic pain populations, evidence from the clinical and epidemiological studies demonstrated that individuals have a variety of sleep disorders such as insomnia, sleep apnea, and restless leg syndrome. A survey of 18,980 individuals from 5 different countries demonstrated that significantly more individuals with chronic pain conditions experienced insomnia when compared to those without pain. In addition, again, when compared to individuals without chronic pain conditions to those with pain, this latter were 3 times more likely to experience difficulties with initiating or maintaining sleep, early morning awakenings, and non-restorative sleep, indicating sleep difficulties. Moreover, a recent large sample size review and meta-analysis from studies that used objective measures of sleep, like PSG, or examined diagnosed sleep disorders by physician and participants with chronic pain, demonstrated that chronic pain was associated with reduced sleep duration, increased sleep onset, poorer sleep efficiency, and more time awake after initially falling asleep. In addition, the pooled prevalence of diagnosed sleep disorders in this sample of patients with chronic pain was 44%, being 72% with insomnia, 32% with restless leg syndrome, and also 32% with obstructive sleep apnea. Furthermore, patients with chronic pain experienced greater sleep fragmentation, more awakenings, and movement-related disruptions to sleep, compared with pain-free individuals. In this same investigation, sleep architecture seemed to be less affected by chronic pain, with only non-REM 1 duration being longer. Remarkably, non-REM 3 sleep, which has a restorative function, was not significantly shorter in chronic pain patients, though it did approach statistically significance, and might have been a finding with no statistical relevance but with clinical relevance. Reduced non-REM 3 sleep of chronic pain patients is presented in the literature with mixed results, with fibromyalgia reportedly being associated with reduced non-REM 3 sleep, and rheumatoid arthritis associated with increased amounts, perhaps as a reparative response to inflammation. Sleep disorders and pain. A recent comprehensive review listed the most likely sleep disorders associated with chronic pain. This included insomnia, sleep apnea, up to sleep bruxism, and rarely narcolepsy. Insomnia is another sleep disturbance considered a risk factor for the development of chronic painful conditions. Complaints with insomnia predicted 93% of the risk of new cases of chronic widespread pain in pain-free participants and were considered a risk factor, increasing by 1.4-fold the chance of developing back pain, with no inverse association. In addition, the treatment of insomnia complaints in participants with osteoarthritis and insomnia leads to improvements in pain severity and osteoarthritis symptoms. Taken together, this data points out to a unidirectionality of insomnia as a plausible risk factor for the development of chronic pain. Obstructive sleep apnea is associated with chronic pain, both in increased prevalence and pain intensity, such as orofacial pain, psoriasis, and immune-mediated chronic inflammatory painful disease, or fibromyalgia. Indeed, clinical symptoms are increased, and prognosis and physical function is decreased when patients present both chronic pain and obstructive sleep apnea, which may interfere in the rehabilitation of musculoskeletal diseases. Another sleep disorder that has been associated with chronic pain or in the orofacial area is sleep bruxism. The association of awake and sleep bruxism to chronic pain is largely debated, and causality remains to be proven. Indeed, sleep bruxism has been categorized as a risk or contributing factor to dental pain and or TMJ disorders, although these reports are very variable depending on the subjective or objective nature of the bruxism reports. Indeed, large polysomnographic studies have shown that the distribution of TMD between bruxism and non-bruxism is similar, and the occurrence of TMD pain is not associated with the intensity of sleep bruxism. Nevertheless, different subgroups of individuals might present different characteristics that can make them more vulnerable to develop pain and or other comorbidity. For instance, a very recent study using recent machine learning in general population of Sao Paulo showed that the association between insomnia and sleep bruxism was more prevalent among middle-aged females when compared to other sex and age groups. Although the investigation of the association between sleep bruxism and sleep continuity and disturbances across different phenotypes is active and progressing, given the important link between sleep and chronic pain, more studies accounting for chronic pain as well are needed. In summary, individuals suffering from sleep disturbances are at elevated risk for the development of pain over time frames from 1 year to 28 years. Together, all these investigations from different groups and countries suggest that sleep impairments contribute exponentially to the development of somatic symptoms, such as chronic pain, and some time point. Mechanisms involved in sleep and pain relation. There are many hypotheses on the mechanisms of sleep and pain interaction. One hypothesis is that brain structures involved in the generation and maintenance of sleep are also involved in pain modulation, thus providing a neurobiological substrate for this relationship. For example, animal studies have shown that the periaqueductal gray matter of the midbrain is responsible for the modulation of both sleep and pain. In humans, sleep and pain processing often share afferent circuits, such as the parabranchial, amygdala, and parabranchial hypothalamic pathways. Likewise, the thalamus is associated with excitation and the processing of nociceptive stimuli sent to the cerebral cortex in animals. Another hypothesis derived from animal research is the pain-on and pain-off neurons concepts. These neurons, which are situated in the nucleus raphe magnus, respectively, facilitate and inhibit nociceptive impulses to the thalamocortical pathways and are influenced by the sleep-wake cycle. Inhibitory pain-off neurons are activated during non-REM-3 sleep, while excitatory pain-on neurons are activated during wakefulness. Moreover, recent human neuroimaging studies have shown that acute sleep deprivation amplifies pain reactivity in the pain somatosensory cortex, and that the degree of this amplification predicts the expansion of experienced pain across individuals. However, sleep deprivation seems to blunt pain reactivity in higher-order valuation and decision-making regions of the striatum and insular cortex, which are brain areas also involved in pain modulation. In addition, sleep disruption increased reward-related connectivity between nucleus accumbens and the anterior mid-cingulate cortex at pain onset, suggesting, among others, that sleep disruption could affect pain via attention and reward mechanisms. Other possible underpinnings of this interaction formed within sleep and pain problems are the increase in distinct inflammatory markers, potentially leading to a generalized inflammatory state, the influence and mediation of mood disorders and affective issues, and the alteration of the endogenous substances apparently related to both sleep and pain processes, such as dopamine or perhaps melatonin, vitamin D, or orexin hypoxyrin, as recently summarized in a comprehensive review. Other hypothesized mechanisms involved in sleep and pain relation describe neuronal and non-neuronal components such as the opioid system, the monoaminergic system, the oxynergic system, the immune system, the pinomelatonin system, the endocannabinoid system, the hypothalamus pituitary adrenal axis, the adenosine signaling, the nitric oxide signaling, among others. Based on the above literature on the interaction between pain and sleep impairments, it seems beneficial to target a deactivating approach on several systems and mediators and complex reciprocal interactions. However, evidence regarding approaches based on the physical therapy that can simultaneously target sleep and pain problems is limited. Thus, this remains a stimulating challenge to better understand this complex and intrinsic relationship. In this sense, physios are essential clinicians to assist patients in their search for better sleep and less pain. Personalized medicine using machine learning and AI approaches from an interdisciplinary perspective could certainly help in the understanding and management of sleep and pain interaction. Management roots in presence of chronic pain and sleep in PT practice. Physios should assess sleep for its quality and restorative perception, and for concomitant disorders as described above, as carefully and completely as possible in chronic pain patients, using both subjective and objective measures. Physios expertise is related to different pain conditions of various etiologies, but perhaps their focus in musculoskeletal pain, in acute, post-trauma, or post-surgical settings, in subacute conditions, in the presence of other chronic diseases, or in end-of-life period. Plan your treatment. If a primary sleep disorder is suspected, such as sleep apnea or periodic limb movements, or if the patient complains of excessive daytime sleepiness interfering with his daily routine, PT should refer the patient to a physician specializing in sleep medicine. A diagnostic sleep study will be probably performed according to the patient's needs. Physios can help with screening using sleep diaries, questionnaires, and pain records that will provide circadian evidence on chronic pain and sleep disturbances, and explain to the patient that the notion on this may interplay with their quality of life. Actigraphy is a technique that monitors activity over a quiet period. It can be performed to give more objective cues on the temporal association between sleep and pain, and to help patients to understand their wake and sleep behavior. Importantly, although physio can help with the screening and treatment of sleep disorders when indicated, it is essential to understand that their management should be conducted by a sleep physician. Therefore, after adequate indications, the physio will proceed to the individualized treatment of the pain condition. One important point to remember is that the first-line choice for chronic pain approaches and techniques are available, including education and self-management. For example, neuroscience pain education or cognitive behavioral for pain. Therapeutic exercise, including strengthening coordination and function. Activities of daily living using of proper body mechanics, motor control. Physical activity and exercise. Knowing the effects of exercise on both sleep and pain to induce hypoalgesia. Passive techniques, manual therapy such as mobilization, manipulation, substitutional massage, muscle energy, traditional massage. Movement therapies such as PNF and global postural re-education. Watsu, a form of hydrotherapy that encompasses stretches, massages, and acupuncture and warm water used for deep relaxation and passive exercises. And electrotherapeutic and dry needling modalities. Note that all chronic pain conditions cited have sleep impairments, such as non-refreshing sleep, fragmented sleep, or disturbances. In addition, sleep hygiene tips and cognitive behavioral therapy for insomnia and other sleep disturbances can be added in order to improve sleep and to make the patient have more knowledge and action in the treatment. Sleep hygiene is always a subject that should be discussed with PT. Furthermore, sleep positioning should be addressed for any sort of musculoskeletal pain. The positioning can always be improved. The restoration of adequate sleep is essential to avoid the exacerbation of painful symptoms, and in this sense, we encourage physios to look at sleep habits or routines and symptoms in patients to seek assistance. Contents covered: what is pain, the comorbidity between chronic pain and sleep disturbances, sleep disorders and pain, mechanisms involved in pain and sleep relation, management route in presence of chronic pain and sleep in PT practice. This is all on the topic of sleep and chronic pain interlaced influences, guidance to PT practice. I'm Chris, signing out.